The normal testicle size is 15 to 20 cc's. To 10 or below is small for a grown man. Soft is important. Anytime someone has small, firm testicles, that is probably primary hypogonadism. So we all see Klinefelter's patients every year that were never diagnosed as kids, which I find shocking, but maybe people are nervous about doing good genital exams in kids when they turn 14, 16. I don't know. But Klinefelter's presents as firm, small testicles. And everything else, which is mostly all the secondary causes, people taking anabolic steroids to get strong, people taking exogenous testosterone, people who are hypopit, they just don't have FSH and LH stimulating the testicles. Remember, those are trophic hormones. So not only do they cause you to make sperm and testosterone, they keep the testicular volume what it is. 90% of testicular volume is just sperm. Only 10% is devoted to testosterone. So small, soft testicles actually do matter. And then testosterone level is low. A normal male is at least 250 or 300, and someone that young probably a good bit higher than that. We see that there's no LH. They pretty much gave it away. After all that reading, you get down to the prolactin of 22,500. They do everything else associated with pituitary. It's fine. He has a macroadenoma. I guess I shouldn't say that. He has a large stellar mass. That would be a macroadenoma if it's coming from the pituitary. And it's elevating the chiasm. So what should we do for this patient? And we get choices are to remeasure things, which in endocrine we do that all the time. That's like the only thing we do when we see the patient the first time. We remeasure everything. You can give him testosterone, start dopamine agonists, send him to surgery or radiation. I'm going to guess no one's going to say A. Fair? Okay, and we're probably not going to start testosterone, because although he may think it's his most pressing issue, it's not. It's his prolactin and his tumor. So what do we do for a large prolactinoma that's causing visual field defects and headaches? So resect it used to be the right answer, and you can still do that, but this is the one tumor that is medical. It should really almost never go to surgery without a trial of dopamine agonist. So even if they are literally can't see anything outside of here, it's amazing. Within a couple of doses, just a tiny bit of shrinkage to take the pressure off the chiasm, and their vision clears up beautifully. My record for this is a 33,000, and Dr. Clemens won't just tell me that's nothing compared to what they've seen. But they respond. So if it's an efficient, these are well-differentiated tumors. They're really efficient. They respond beautifully. There are resistant tumors that go to surgery, but that's not what they're going to give you. Okay, so this is the one tumor in the pituitary that gets medication, Cabergoline or Dostinex. Everything else pretty much goes to surgery. So if you're given a growth hormone secreting tumor, a Cushing's tumor, a non-functioning tumor, they have to come out if they're making hormones or if they're pressing on anything, because there's not really good medical treatment. There's medical treatment for acromegaly, but it's adjuvant treatments after it's been dewelled. Okay. All right, so adrenal. Any pressing pituitary questions? Okay. So you remember adrenal anatomy. So these three zones, the cortex, are mainly what we deal with on the boards, I think. Mainly the middle layer, the fasciculata that makes cortisol, and then we'll get some hyperaldo questions that come out of the glomerulosa. I don't think you'll really get any questions about adrenal androgen synthesis in the reticularis here. And then here, the main question you'll get is Pheos, tumors that arise from the medulla. So like many things in endocrinology, adrenal pathology can be excess function. Obviously, if your top layer has excess function, it's hyperaldo. It used to be half and half tumors and idiopathic hyperaldosteronism. We're finding out many of these patients are idiopathic hyperaldosteronism. So we're using a lot more spironolactone and eplerenone and a lot less surgery. But those are your two things on the differential. Cushing's, I put 2 stars by because there's tons of questions on Cushing's. And Pheochromocytoma is kind of important because they're part of the MEN2 syndrome. Hypofunction is easy. That's just adrenal insufficiency. So that's either Addison's, which is autoimmune, or adrenal insufficiency due to surgery, hemorrhage, or secondary adrenal insufficiency, which is more of a pituitary issue. And then incidentalomas, again, conveniently are defined by a centimeter. So there's no such thing as a micro-incidentaloma in the adrenal gland. If it's under a centimeter, it's not really called anything. We're not supposed to technically work it up and do all the things we do for something that's 1.1 centimeters. But likely they'll give you something that's a nice 2 or 3 centimeters. And then you have to make sure it's not cancer, and you have to make sure it's not making anything. So cancer is largely evaluated by size. Anything that's over 4 centimeters, you really ought to think about taking out. Anything over 6 centimeters has to come out. Under 4 centimeters, you can look at Hounsfield units and characteristics for cancer. So this is a 38-year-old woman who has gained 13 pounds in the last couple of years. Her blood sugar is high on 2 occasions. She doesn't really take any medicine. Her blood pressure is high. So up until now, she's just sounding like metabolic syndrome, like anything in your clinic. But then they give you a couple more interesting things, that she has terminal hairs, mild acne, violaceous striae is a buzzword. So wide purple striae matter, wide pink ones don't. So any of you who have had kids, wide pink striae are perfectly fine. Thin striae are fine. Her face is full. She's skinny arms and legs and a big abdomen. So after all that, you know the patient has Cushing. So what they want to know is, what's the first step in evaluating Cushing? So we have serum cortisol at 4 p.m., 24-hour urine cortisol, a morning cortisol after giving her dexamethasone the night before, just measuring an ACTH or going straight to an MRI. And I think there are 2 really reasonable answers here. So can we rule out MRI of the head as the first one? I'm going to guess no one's going to say an ACTH yet. You all know it's part of the algorithm, but it's not the first step. So your first question is, does she have Cushing's? That's always the first step, right? So she could just be taking a heck of a lot of prednisone. You know, there's lots of ways you can get Cushing's. But does she have Cushing's? So how are you going to find out if she's making too much Cushing's, too much cortisol? 24 hours? So whatever wants to make her collect a 24-hour? Yes. So that is the right answer. C could have been the right answer if they had changed this to what? 1 milligram, exactly. So there is a high-dose dexamethasone suppression test that's later on in the algorithm, but the 2 ways, three ways really you can figure out if someone has Cushing's is, 1, make sure they're not on any steroids, do a good medication history, because oftentimes they got a shot of something in their back 3 months ago, and that can make you look Cushingoid transiently. So after your medication history, you can either make them collect a 24-hour urine cortisol, you can check their morning cortisol after giving them 1 milligram of dexamethasone the night before, because a normal person, dexamethasone is potent. If you take it at midnight, the next morning your cortisol should be under 2, typically. We used to say 5, but under 2 is a better cutoff. Okay? So if you don't suppress with a milligram of dex, if your 24-hour urine cortisol is high, we won't get into how high, but it's high. And the third way is you can do midnight salivary cortisol. In the olden days, they used to just bring people into the hospital at midnight and draw their serum cortisols at midnight, because that's a great way to do it. You know, you should have almost no cortisol at midnight if you draw a venipuncture. And if you have Cushing's and you have lost your diurnal variation, you'll still be making plenty of cortisol at midnight, but insurance doesn't cover that anymore. And salivary cortisols are a pretty decent way of doing it. They're not super standardized from lab to lab, so I think for board's purposes, do your 24-hour urines and your 1 milligram overnight dex suppression. And so that's what we just talked about, was how we figure out if they're actually making too much cortisol, or those 3 things. If your answer is yes, so clearly high, your second question is the big branch point. Is it ACTH dependent or not? That's a big, big question. If you're lucky, it's not ACTH dependent. So if the ACTH is really, really low, then where is it coming from? Pituitary or adrenal, if the ACTH is very, very low. Adrenal. Okay, so that's really a nice, because it's not going to be a micro tumor in the adrenals. It's usually a nice big tumor. And so that's always very satisfying, unless the person has an adrenocortical cancer. That's not good. But otherwise, it's generally a very satisfying thing, because if their ACTH is under 10, especially under 5 or 1, you just do CAT scan or MRI of the adrenals and surgery, and the person's generally fine. So if it's ACTH dependent, which unfortunately is like 80% of all Cushing's, then you have a lot of work to do. And I'm surprised to keep seeing these questions on the board reviews. I don't know if they're really on the boards, but they're on all the mixed apps, and they were on, I don't remember my boards, but they keep showing up. So if it is ACTH dependent, you have to ask yourself, is it coming from the pituitary or somewhere else? Because ACTH can be made by a lot of tumors. You guys have probably seen like small cell tumors on the onc wards in the late stages that make lots of ACTH. It's not a diagnostic dilemma in those cases. But you can start with an MRI, and if you're really lucky, you'll find a nice big tumor. But most Cushing's tumors, and I think there's this one lady on the wards that like everyone's worked up now. But so she's a great learning case. You'll never forget pituitary Cushing's, you know. So if you have a nice big tumor, which you almost never have in Cushing's, most of these are microadenomas. Unlike acromegaly, where most of them are big tumors, most of the time your MRI is going to be negative. And then we do things to try and suppress it. So the whole point is a normal person's pituitary will suppress easily with just a milligram of dex. A pituitary adenoma is not super undifferentiated. It'll suppress, but you have to do high-dose dex suppression, which can be done in lots of different ways. And so that's the theory behind this test. But if you suppress to this, then it's probably a pituitary source. And then inferior petrosal sinus sampling is just putting basically catheters in the veins that drain the pituitary and making sure that the ACTH there is 2 or 3 times higher than the ACTH in the periphery. Okay, because then you again know it's a pituitary source. So it's kind of complicated to figure that out. So if you don't want to spend a lot of time on that, you don't have to. Most of these things, if you start out here, almost all of them end up being pituitary in real life, just so you know that's the most common cause. Cushing's disease, which is pituitary Cushing's, is the #1 cause of all Cushing's. But there's lots of other things it can be. So another woman with weight gain and fatigue, she has impaired glucose tolerance, wide striae. She has a clearly abnormal urine-free cortisol. So we've answered the question. She has Cushing's. She has a low ACTH. She gets laparoscopic adrenalectomy. So this was a nice, easy patient who has adrenal Cushing's. But then she's hypotensive and nauseous. So what's the most appropriate management at this time? D. So you know this. This is easy. Stress-dose steroids. It can take 1 or 2 years to wean these people off of their steroids if they've been Cushing really for a long time without diagnosis. And, you know, it's kind of frustrating for them because I thought they'd go often after surgery, and they don't. And it takes a long time to get them off their steroids. So headache, 28-year-old woman, headache, sweaty, episodic hypertension. She has very high plasma metanephrine. So these are the type of questions where I just wouldn't read the rest of the questions because they're telling you what it is. And so you want to know what do they want to know. And so here's a positive RET mutation would indicate the presence of which. So you don't even need the whole paragraph. All they're saying is what is RET mutation associated with. And the paragraph is just completely extraneous. There's no reason to even have it there. But you guys have all heard of RET mutations and what are they associated with. Okay, so she has a Pheo. Her mother apparently had a similar evaluation. She had a parathyroid surgery. Her grandfather had a Pheo and medullary cancer. So they gave you all this wonderful thing, and they just want to know what this RET associated with. So does anyone remember what RET is associated with? Is it A, B, C, or D? A. So one of them. That's a great answer. So no, that's true. This was on like in your med student thing for your studying the 10% tumors and all those things, and it's the same thing. So this is MEN2. So it's not hard to remember these. They're pretty quick. So forget primary aldo. There is no hereditary syndrome associated with primary aldo. So if you have a tumor that just makes aldo, that's called Conn syndrome, but it's not really a syndrome. It just happens. This is very misleading. So polyglandular endocrinopathy is also known as APGS1 and APGS2, so autoimmune polyglandular syndrome. And this is actually at least one type of APGS. APGS1 is associated with one specific gene mutation, and these patients just get autoimmune glandular failure in multiple glands. So they get hypothyroidism, hypocalcemia because their parathyroids fail. It's extremely rare. There are a couple of family cohorts. It was called APGS1 because they didn't know the genetic basis back when. There's an APGS2 that's really common, which is just autoimmune adrenal insufficiency, meaning Addison's, associated with either hypothyroidism or with type 1 diabetes. So all my Addisonian patients, as soon as they get one more autoimmune disease, I tell them they have APGS2, and that one doesn't have a specific genetic mutation that's known. Okay, so those are really rare things. You know, most of us don't have many of these people in our clinic. But MEN1 and 2, you do need to memorize those because they show up in a lot of different forms. They have nothing to do with one another. This is, again, preceding genetic testing, so they're just multiple endocrine tumors in multiple glands, and they called one of them 2 and one of them A. 2A is what this is. So 2A is, somebody knows them. Pheo, what else? Medullary, thyroid carcinoma, and what does the mom have? So parathyroid is the least common. So medullary is the most common, so most of these families, especially if it's a 2B family, they end up having their thyroid taken out by age 10 because they get cancer, and medullary cancer is a purely surgical disease. There's nothing else that really helps. MEN1 is completely different. So MEN2A is caused by mutation of the RET proto-oncogene, so people's cells just grow. MEN1 has genetic basis, but it's a little more difficult to test for. A lot of times you can't find it. It's a mutation in the tumor suppressor gene. And this is the 3P syndrome. So MEN1 is parathyroid, so usually hyperplasia, sometimes adenomas. And what else?